Okay, thank you for tuning in. Gastroenterology and Hepatology Advanced Practice Providers has created the MASLD community network to support clinicians in managing patients with metabolic dysfunction associated steatosis and steatohepatitis. So today we are going to talk about comparing F3 and F4 fibrosis. So why is this important? We know that accurate fibrosis staging in metabolic dysfunction associated steatotic liver disease or MASLD is critical because fibrosis stage is the strongest predictor of liver-related and all-cause mortality, risk of hepatic decompensation, and hepatocellular carcinoma development. So all these non-invasive testings or NITs such as FIB4, vibration-controlled transient elastography or VCTE, and the enhanced liver fibrosis or ELF test are now central to the risk stratification and management, reducing the need for liver biopsy and guiding referral and surveillance strategies. So in this presentation, we are going to talk about a certain patient but with different scenarios, two scenarios. We call it case A and case B. So my name is Tuesday Werner, and I'm honored to do this presentation today. So the core objectives of this comparison is to illustrate the critical importance of accurate fibrosis staging in liver disease. So we're gonna discuss why accurate staging is crucial for prognosis, risk stratification, and management decisions. And two, the difference in care pathways and clinical implications that arise from varying fibrosis stage, specifically in case 6A with F3 and in case 6B with F4. So please use this QR code to register for this meeting. So let's talk about this patient. This is case 6A. So Sam is a 55-year-old male referred for mildly abdominal transaminase levels with an abdominal ultrasound showing increased liver echogenicity. The patient's main complaint is fatigue. So he is 55, he is Caucasian, and his BMI is 33 kilograms per meter squared. Continuing on, the patient's medical history. He has diabetes mellitus type 2, hypertension, hyperlipidemia, sleep apnea, and do not use alcohol. Physical exam, he's obese. There's no stigmata of advanced liver disease, and there's no hepatosplenomegaly. Medications, he's taking lisinopril, rosuvastatin, ezetimibe, and the pacliflozin. And these are his vital signs and labs. So vital signs, his blood pressure is 140/78. Heart rate is 76, temperature is 98.4%, and his weight is 235 pounds or 106.8 kilograms. And again, his BMI is 33 kilograms per meter squared. Laboratory test showed ALT of 85, AST 72, alkaline phosphatase 120, total bilirubin 1.1 milligram per deciliter, platelet of 157,000, and hemoglobin A1C of 7.1%. Additionally, his creatinine is 1.1, INR of 1.0, ferritin 780, iron saturation of 30%. His ANA is 1:80, and the rest of the chronic liver test is negative, like the ASMA, hepatitis C, Hep B surface antigen, and Hep B surface antibody. So this is the NITs that the patient had. So looking at this, his FIB4 score, which has probability of F3 and F4, his score is 2.74, putting him on intermediate risk. The FibroScan had 11 kilopascal, which putting him on significant fibrosis or F3. And the CAP score, steatosis score, is 262 with moderate steatosis. And the ELF test result is 9.9, putting him on a severe category. So the reason why we do all these and non-invasive tests is so we can, obviously measure the fibrosis score, but also to not do any more liver biopsy, which is very invasive and costly and not scalable. NITs help distinguish the risk, including FIB4 with initial risk stratification. The FibroScan or elastography detects fibrosis, which is greater than like F2, which is significant. And the ELF test, there's also this MRI, PDFF, and also serum biomarkers, which also add precision in assessing the fibrosis score. Now, the clinical significance of this is that it identifies patients with MASH and plus fibrosis who need closer follow-up, hepatology referral, or possibly pharmacotherapy such as resmetirom. And then it also avoids overburdening the system with unnecessary referrals for low risk MASLD. So knowing all the data that we have, as mentioned above, question is there any further testing you'd like to perform on this patient, and how would you stage this patient? So again, looking at all the NITs, we have the serum NITs, such as the FIB4, the MASLD fibrosis score, or the enhanced liver fibrosis, and it's accessible, it's inexpensive, and can be done even in a primary care setting. It provides information with fibrosis risk stratification from low, indeterminate to high, although the limitations is that it's less accurate, especially in younger patients, acute illness or mild disease. And there's also this indeterminate gray zone values that is common, and it does not quantify steatosis. The imaging-based NITs, on the other hand, like the FibroScan and magnetic resonance elastography, it measures the liver stiffness and also the CAP scores or the steatosis score. It is accessible, moderately available in hepatology centers, and however, the point of care is already expanding for FibroScan. MRE is also limited to tertiary centers, and it is costly and less available. Although the information can be provided with the fibrosis stage, with the and the steatosis, and also MRE is most accurate in non-invasive fibrosis tool. MRE can also be very expensive. So for this patient, knowing what we have, is there any further testing you'd like to perform on this patient? So we know that he's on a stage of fibrosis 3. So testing-wise, I don't think we need to do any more testing. We know he's fibrosis 3. So how would you treat this patient, and how would you monitor this patient? So for patients with F3, the main thing is that we integrate NITs to our clinical decision making. So we start with the patient context. We look at the comorbidities, the patient's diabetic, obese, hypertensive, and dyslipidemia. Lifestyle factors like alcohol intake, diet, exercise patterns. We look at family history. Is there any family history of cirrhosis, liver disease, or HCC? And also the medications the patient's taking, any statins, hepatotoxic medications. And then we look at the patient's laboratory assessment, elevated liver function tests like the AST and ALT, ALP-FOS, total bilirubin. We look at the albumin, the INR platelets, or what we call the synthetic function of the liver. And then we look at the pattern. Persistent ALT elevation can lead to a higher concern for MASH. Platelets plus AST, ALT feed into the FIB4 and other NFS. And then we look at the NIT result. So this patient particularly is indeterminate. So they did this imaging NIT, and the FibroScan showed that he is on intermediate risk. So again, we integrate and individualize the care. For young, healthy patient with MASLD, normal LFTs, low-risk NITs, we monitor every 2 to 3 years. Patients who are diabetic, obese, patient with indeterminate FIB4, and the FibroScan is about greater than 9 kPa, we monitor annually and we refer to hepatology. Patient with high NITs, abnormal LFTs, on cirrhosis signs, urgent hepatology referral, and consider HCC surveillance and variceal surveillance. So for this patient, knowing that he is on intermediate risk and he is on fibrosis 3, we considered starting resmetirom, lifestyle modifications, and consider GLP-1, and also monitor for HCC. So again, intermediate risk, intensify metabolic management is very important. Closer follow-up, hepatology referral if worsening. So as we proceed, now that we talked about F3, imagine if this patient of the same profile but different NIT findings. So we look at Sam. Again, the same profile. He is diabetic, hypertension, hyperlipidemia, sleep apnea, no alcohol use. Physical exam is pretty much unremarkable. He is obese, and the medication he's taking. His BMI is 33 kilogram per meter squared. And these are his laboratory tests. His blood pressure is slightly elevated, 140/78. And he does have positive ANA of 1.1:8. Otherwise, his elevated liver tests, mildly elevated AST and ALT, as well as the total bilirubin of 1.4. So the same patient, but this is the NIT score of this scenario. So the FIB score, probability of F3, F4, it's 3.36, which is high risk. And then his FibroScan result, 21 kilopascal, again, greater than 12.5, advanced fibrosis, or F4. And his CAP is 245, basically moderate steatosis, and his ELF is also higher, 11.4. So again, question is there any, oops, sorry, let me go back. Is there any other further testing you'd like to do in this patient, and how would you stage this patient? So far, we know that this patient likely is in the F4, fibrosis 4, based on the NITs. We again do stage this patient as F4, but the management is not slightly, but different when it comes to managing this patient. So let me put that here. So for this particular situation, Sam needs diet and lifestyle optimizing management of metabolic syndrome, monitor for development of HCC, and screen for esophageal varices, and then consider obviously more further evaluation if there's further decompensation or signs of decompensation, such as ascites, development of hepatic encephalopathy, and timely management to transplant centers. So comparing the patient scenario, 6A, the patient of FIB4 of 2.74, ELF score of 9.9, and transient elastography of 11 kilopascal with cap of 262. 6B, his Fib4 is 3.36, his ELF score is 11.4, and transient elastography of 21 kPa. Clearly, this 6B is fibrosis 4, and 6A is intermediate or fibrosis 3. So, comparing the patients and its management, and staging between F3 and F4, which is kind of it's tricky because of its subtle changes, but the NITs is a lot more higher. So comparing this F3 and F4, we know that prognosis worsens significantly at F4 due to increased risk of decompensation and HCC. So surveillance, intensity, and urgency of specialist referral increase at F4. And the drug options narrow due to the safety concerns. So NITs have limitations in distinguishing advanced fibrosis from early cirrhosis, and that liver biopsy may be needed if results are discordant or management will change. So according to the New England Journal of Medicine, non-invasive tests such as Fibrosis 4 Index, the FibroScan or vibration-controlled transient elastography, and the enhanced liver fibrosis tests are effective for identifying advanced fibrosis, F3 in MASLD, but have limited accuracy in distinguishing F3 from cirrhosis or F4. We know that Fib4 is widely used for initial risk stratification with scores greater than 2.67, indicating high risk for advanced fibrosis, but it cannot reliably differentiate F3 and F4. VCTE, or liver stiffness measurement, and ELF improve diagnostic performance, yet overlap values between F3 and F4 stages remain substantial, and up to 20 to 30% of patients have indeterminate discordant results. And again, liver biopsy should be considered when NITs yield indeterminate, discordant, or borderline results, and when precise staging would alter management, such as determining eligibility for HCC surveillance, variceal screening, or specific pharmacotherapy. And that the rationale is that cirrhosis or F4 confers markedly higher risk of hepatic decompensation and HCC, necessitating more intensive surveillance and intervention, whereas F3 management focuses on metabolic reduction and monitoring for progression. So why fibrosis stage matters, F3 versus F4? Because F3, advanced fibrosis or bridging, has significant risk of progression and up to 20% progress to cirrhosis over 5 years. Management priorities for these F3 patients: aggressive metabolic risk factor control, like the diabetes, obesity, and hypertension, lifestyle intervention to slow or at least stop fibrosis progression, and then close monitoring with non-invasive tests with the FibroScan or ELF every 6 to 12 months. Consider pharmacotherapy like resmetirom, of course, in approved population, and surveillance, which is not yet cirrhosis, so there's not really surveillance needed. But if they are in F4 or cirrhosis, there's architectural distortion of the liver, which highest risk for decompensation and development of HCC. And the annual risk of HCC is about 1 to 3%. So management priorities: HCC surveillance, ultrasound, and AFP every 6 months, portal hypertension screening, endoscopy for varices, and non-invasive risk tools. Manage the complications such as ascites, encephalopathy, and variceal bleeding, and also evaluate for liver transplant referral if decompensation continue. So teaching pearls is that F3, watch closely and act early to prevent progression, and then F4, surveillance and protect, focus on preventing decompensation, HCC development, and timely transplant referral. So visit the GAP MASLD MASH Community Network for additional disease state education and Restifra webcast. You can scan this QR code. And also, you can scan the QR code to complete the short survey and scan your thoughts on today's presentation. Your insight help us to continue to improve. And if there is any questions, I'll be happy to answer. Thank you.